Good afternoon, friends. After listening to a wonderful, retina presentation, where the fluid can be taken off with, one injection and improve the vision quality. But whatever said and done, I think, life has changed, especially in people with cataract or people who operate cataract after getting a good intraocular lenses. And this session is on a premium IOLs. So let's see how things have changed in recent past. We have Dr. Nossi Sroff, one of the most respected, senior most person in intraocular lens surgery-wise, innovations, experience. And we have Dr. V.C. Mehta, who's sitting down. Please come, sir. You are a co-chairperson. We have Ajay Sharma. Please come. Dr. Sonu is already here, and Anurag Mishra I don't see here. Sheetal also not here. Gaurav Luthra busy with conference management. I request Sonu to start the session.
So very good morning, and without wasting much time, I would like to invite Dr. Parul Sharma. Is Dr. Parul Sharma around? Okay. So is Dr. Jitendra Wahi here? Yeah. So can you please... So we have Dr. Jitendra Wahi, and he'll be talking on advancement in the world of microscope. So let's hear from him. I think it's a very prized commodity that he'll be talking of.
So, good afternoon, friends. My regards to the esteemed dignitaries sitting on the dais, as well as all the delegates in this hall. Today, I am going to talk about a microscope. So, what we have been always hearing is that what mind doesn't know, the eyes can't see. But what I believe now is that what I can't see, the hands can't perform too. So now, it's very, very important that let us talk about something for performing a good surgery you really need for yourself also. Rest everything you are doing for your patients, but this is something which is going to give you a good vision. And then there is another question, that when we have got such big stalwarts already into the market, if I take the names also, for example, Zeiss or Leica or many other big brands, then what is the need of something else? That reminds me of the latest Birla Opus paint, what they are now advertising. Then when the old is gold is already standing, then why for the new? But this is the time when it comes for a technology to intervene. A new microscope with technology at its prime explains in another 10 minutes how the things go about. Now I'm going to talk about Alcon microscope. This is Luxor Revalia, which is going to give us surgical integration and superior visualization. Now, what do you exactly mean by it? My disclosure is that I am talking on behalf of Alcon. I have their support, I thank them. Now, when I talk about Luxor Revalia microscope, this entity, if you have not seen, is something to see to believe. Because the points which I'm going to talk about, when I talk about superior visualization or large field of depth, or what is the level of red reflex you are going to see, that will be comparable with the already standing giants what we have seen in the past and what we are performing. So when I talk about this microscope, the technology as it advances right from the time of tape recorders to the CDs and then to the pen drives and now to Bluetooth and all those things. Similarly, we have come to an aluminum eye technology, which is at its prime, supplemented by non-focused LED illumination and apochromatic optics. Now, what do you exactly mean by it? Now, we have always seen those microscopes where they were the modern microscopes, and we have been operating for a long time. It was all the game of the objective lens, how it is placed into the light pathway of a microscope. And that defines the level of red zone, red reflex, and the volume of red reflex what you can see. This is a game-changing point. Earlier, the objective lens placement has already been below the light source, so that the light was converging on the cornea, going inside and getting focus on the retina and getting reflected back. So that convergence factor, you can see there, gives a small red zone. But here, the Alcon technology has completely revolutionized the placement of this objective lens. They have placed the lens above the light source. So now, you are seeing from the top, the light is going into the eye, but it is in a divergent fashion. And the way it is getting focus on the cornea and getting it to the eye is approximately 6 times larger than the conventional. So what I say is, you have to see to believe it. The difference and the size of the red reflex, you have to see to believe what difference it is. This is an Alcon proprietary illumination technology. The second thing is, the red reflex, when I say 6 times larger red reflex zone, this gives you an absolute stability. Even if patient has a micro movements of eye or head, because you are doing a topical this thing, it's not going to disturb you. It has got, you can see the beautiful lens, anti-capsule lens and anti-chamber structures, and consistent visualization of capsular edge, even if there are micro or macro movements. And if we are talking of operating on an aphakic eye, where the maximum light is going inside the eye, this also gives you a beautiful safety exposure time in dilated aphakic eyes. And it is comparable with all the brands available, that it enables a longer safety exposure times in an aphakic eye, because just of that one factor, how the objective lens has been placed in the light pathway. When I say about largest field of depth, the objective lens is so placed that you have got a big working distance as compared to the conventional microscopes which are available in the market. And this is 33% times greater depth of, this gives you 33%, it's significant, it is significant. It gives you 33% extra greater depth of field. What do you mean by depth of field? The working distance is really big. You can move your hands very freely. The whole microscope body is not very close to the eyes. And this is just because they have absolutely changed the position of the objective lens, what we were having earlier. Again, it is just to see to believe this thing. Now, what do you mean by depth of field? In the lower half of the image, you can see all those coins. In the conventional microscopes, you can see that continuum of the vision that is not blending that finely from the first coin to the last coin, but on the top part of the image, you can see how the first part and the last part is equivalently focused, well focused into your sight. This is just because of that proprietary Alcon illumination technology, which gives you a view which is an extended depth of field, which gives you a clarity right from cornea to the lens. And it gives you precise detail, depth of perception and contrast from cornea, as I told you, a crisp view. The another thing is that they have got the second point, first was the placement of the objective lens, second is apochromatic optics. Whenever a light passes from a refractive surface, it gets split into its microcolors, all those individual refractive lenses. This is a lens, this is a microscope which is having a objective lens which has got an apochromatic optics. So it gives absolutely unifusion light, a pinpoint light which prevents chromatic aberration, and you can have an absolute fine vision when it is a matter of surgery and when it is a matter of focusing on the near things. Moreover, the third thing they have got an LED light, which all other microscopes also boast to have, but now they have got a system where you can blend the warm light, the cool light, and get into a pattern whatsoever you want just by a very small fader button which is available on the screen. You can move that button and you can mix warm, cool and this thing and get a light of your own composition. This microscope has got a coaxial illumination which all the microscopes do already have. This is a place where they position 0 degree from the original source of light, and this helps you this is available in all other microscopes also, and it gives you a vision which is really precise for doing the surgery. And they have also got an oblique illumination which they position the light at 9 degrees from the origin of light and this is helping you to see the transparent or semi-transparent objects like cornea or posterior capsule. This also is present in all other microscopes. But the other thing is that you can blend the coaxial and oblique illumination just by your footstep. This is something different. There is a fader system where you can move from left to right, and you can blend coaxial and oblique illumination as per your requirement while doing surgery at just by your foot pedal. So this is how the dial looks. This is how there is a complete dial available, and you can utilize each and every property. The other thing is that this system is co-aligned with other conventional equipments of the Alcon. Centurion machine is linked to it. Varion machine can be linked to it. You can the link Ingenuity. You can all wirelessly. That is the beauty. The entire suit works at your foot pedal. So this gives you a total different touch, as well as they have got a system which provides you a real-time surgical guidance through your ocular systems. You can record your cases with external monitors or additional equipments, and that too you can do on the additional screen which is provided to you just by the side of the microscope. So it has got a powerful visualization, easy to operate, easy to record. You can record your entire surgery on MP4 format directly to USB device using single touch. And when I say superior visualization, it is 48% greater magnification, 42% finer depth of field, and 5 times greater depth of field. This is a system which removes the beam splitter from your optic path. Now this is again a beauty, and it provides 100% retro illumination. So I will say, you have to just to see it, to believe it, and you can enjoy the technology at its prime. Thank you so much.
Thank you, sir, for evaluating wonderful technology of microscope, which is so very important to execute a nice cataract surgery.
Thank you, sir.
So red glow is always better all the time during the surgery.
Always red glow. Thank you.
So can we have, thank you, Dr. Wahi, for that wonderful presentation. So we'll have questions after the session. Can we have Dr. Parul Sharma, and she'll be talking on going beyond biometry. So I think premium IOLs, biometry is the first and the foremost essential tool. I can request Dr. Sheetal, if she's there. Sheetal, you can join us on stage. Yeah, all to you, please.
Good afternoon, everybody. And
can we have the timer here? Can you just put it for 8 minutes? Yes, the timer.
Timer is on the screen.
Fine.
May I? Yeah. Good afternoon, everybody. So we are all talking about premium IOLs, and we all know that the cataract surgery is no more just a restorative surgery. It's a cataract refractive surgery where almost every patient is demanding now to be less and less dependent of the spectacles. So in our armamentarium, it's not just the regular A scan that you have. You have your biometers, which have gone way and beyond the regular ones. You have your topographers of the world, and then you're combining the technology to best get the results and be bang on 6.6 N6 in most of your premium IOLs. There's a lot of astigmatism in a general population. This is a study conducted by Alcon in 16 centers of Maharashtra, where amongst all the astigmatism, only 13 to 17%, like very few opted for a T2 model. T2 means the minimal astigmatism correction, like a 0.5. A little higher number, again that, and around 15-20%. So the need actually is for almost 60% of your cataract surgery, but what we see in the practice, especially in beginning when you're not doing that much of toric lenses, is about 15-20% of your practice being toric lenses. The reasons are many. One is our own place selection. As we grow, we choose minimal and lesser astigmatism to be corrected. Affordability remains an issue, though with Indian lenses and toricity in them, that's becoming much better. And getting your A constant and bang on results, because if you're seeing a 0.5, you're still hesitant, should I not go with toric? So this is the idea that we go beyond biometry. We see what is available to us in the market and then improve our astigmatism and toric corrections. So here I'm talking about a newer generation biometer, that's Argos from Alcon. It uses the SWEPSUS technology. The beautiful part of this is that the acquisition is so fast that it is very less dependent on any kind of eye movement. So the learning curve for any optometrist becomes very less. It is highly precise because it's taking a reference age of digital guidance, which takes simultaneously from anterior to posterior and posterior to the one, being a real time saver. In our practice, in the past few months since we've had ARGOS, surprisingly, I'm getting optical biometry results in most of the dense cataract also. In past 3 months, I've actually had only one patient where I had to do an immersion A scan. So this is where I feel that where other IOL masters like biometers, lag, this one takes over because of its enhanced retinal visualization mode. So this is really helping us and making us confident in using in all kind of patients. So almost in all dense cataracts, we were able to get our biometry reading. They have a segmental axial length approach in the sense that the wave-light for every individual part of the eye, we know that the refractive indexes are different. So unlike other machines where they compensate and calculate, this will actually take you through different refractive index of the wavelength and combine it together to give you the accurate result. The best part is the analyze mode. Once you've taken the acquisition, we train the optometrists to check on every single parameters on how they have acquired the image, right from checking the head tilt, there is a parameter, then you look at your graphs, then you look at your outliers, wherever you see that your measurements, out of the 5 measurements for in kerato, if something is like a 0.2 out or a 0.1 out, the machine will highlight it. So out of your 6 reading, you take away 2 and you keep your 4 best to give a bang on results. So at every point you can analyze and customize it. Now in our previous one, we had a lens star. We were very particular about looking at the head tilt. Every time we wanted to do a toric, they were trained, please look at the head tilt, please make sure that the head is straight. Just for demo purpose, we've put our patient first with a tilt on the biometry, and on the second patient, when we put the head straight, you can see that there is a difference in the acquisition of 10 degree. That's a significant difference. So one take home is that when you please tell your optoms always to look at the head tilt when they are doing the measurement. Now with the ARGOS, even that is taken care of. Of course, we ask them to look at the head tilt, but the acquisition is such because the image captured in whichever way, limbal recognition, that when you put it on your virion in your OT, it's going to be the same axis. So even if you have erred by little, it is not going to come up in your results and not affect your post-operative results. So that's again one beautiful part of this machine. Now the planner, it helps you to do all, like on one click, like other biometries also, you have all the formulas. You should be able to know when and how to choose. Most of us are now happy with Barrett suite because that completely takes care of all. But still, you on a drop down, you can decide in higher or shorter lens if you want to look at other formula. Almost everything here can be personalized and customized. See, going premium means that we are trying to be 6.6 and 6 in most of our patients, so there is a journey for us also. Like we all calculate our SIAs. Simple ways to just calculate your pre and post results, give it to the company people, they'll calculate the SIA for you. But after your SIA, after each pre-op, we put our patients back on the biometer on the 3rd week, for the machine to calculate how much is the cornea keratometer, and by the artificial intelligence, it improves on your SIA so that going forward, I don't have to bother about my SIA and the machine does it for me. So you can put your incision location, you can customize your IOA, you can customize your formulas and target your post-op spherical equivalent accordingly. So this is the configuration that the machine has to improve that. Now in astigmatic planner, it's a real-time thing. Suppose you have a small model of a 0.5. Now, a 0.5, I don't want to do a toric if it's a with the rule. I'll manipulate my incisions, put it on the steep axis. Many a times, my T2 model can become non-toric, saving of 15,000-20,000 rupees for my patient, effectively having the same result. Again, optimizing even a small 0.1, like if I'm not so happy with my first graph here, which says the 0.1 cylinder, and I optimize, I look at where my incisions I can place, I change my incision position, and I land up with just a 0 cylinder in my post-op calculation. Similarly, you have all the formulas, especially for post-refractive corneas. You can use Barrett True K, and you can even use Barrett Total K, where if I have a pentacam, so I pick up the posterior corneal astigmatism reading from there, put it on my ARGOS machine and get an actual real time, not an assumptive posterior corneal, a total K, but an actual total K, and then calculate my post-refractive biometer. So this parameter has also helped us a lot in post-refractive patients. Exporting the surgical plan from the biometer is just a click. You can either do it on a pan drive or a LAN system from where your OPD, all the data will go into the OT. You don't need printouts except for the documentation purpose. And this is how it will get fully integrated into your system and on the phaco machine within the OT on different parameters. So if we go inside the OT, this is how the DMM looks. There's a screen where you've got your Virion planning, and on the phaco machine itself, we have the different stages of the DMM planning on the foot, like how you switch from your phaco quadrant chop to IA. This planning is also on the foot, which makes it completely person independent. I don't need anybody to do anything for me. Once I have the data in, I can keep getting real-time information on my microscope through my foot pedal, through my phaco machine. So this is how it will start. The Argos biometry, which we have done in the OPD, the results are going to come here. So we have, suppose in the list, we have all our patients ready. वहाँ से वीडियो ऑन कर सकते हैं इसका?
I'll request you to
Wind up?
Oh, yeah, please.
Okay.
Yeah. Maybe just.
Sure. So this is a direct overlay which I was trying to show otherwise. I think the videos are not working. And because of the laser overlay, I don't have to do toric marking anymore. No smudging of ink, no marking, no paraffin. This is a small pupil. There's a laser overlay and I'm just lifting it up to see that my toric alignment is proper. So basically a laser overview digitally on the planning that I have done in the OPD onto the OT to get the precision very high and the results accurate. Thank you.
Thank you, Dr. Parul, for that wonderful talk. What we saw was that this machine was linked to the Zeiss microscope. So I think it can be linked to any of the microscopes.
So this is not on the microscope. The display, the DMM is a separate monitor that they give you. So you have to keep seeing the monitor, but they have an overlay in the microscope so you can see through your eyepiece also. Exactly. Yeah. So it can be integrated with any microscope. Plus any machine, I think the machine part foot switch will be with Centuria only.
No, it cannot
Actually,
be.
it cannot be. We have an Argos parameter. The Argos parameter now has a Varion built into it. And the Varion, earlier you used to get a Varion separately. Now you get a Varion with the Argos parameter. And then you can transport it directly to the operation theater. Yeah. So I don't think you can use it on the Callisto eye.
No, what she means is, sir, the MID, the microscope interface device, which sits between the eyepiece and the objective lens of the microscope.
Yes.
What you're saying is right. It can sit on any microscope, but not on the very low-end microscopes. It has to be beyond the Lumira eye level.
Achha, that way, but it has to be the same system.
It has to be
the
same
system. It can't be the Zeiss system.
No, it can. I have a Zeiss microscope, sir.
No, the microscope can be Zeiss. That is true, but it is the Argos. It can't be a Zeiss. IOL master which can be used. The Argos will send data to the OT. The Argos will send data to the OT, and this can be the DMM, which is under the microscope, can be linked to any microscope, and this device can be.
When you had the different, the system was not having the biometer.
Yeah.
It was called Varian. Yeah. The data used to come from the Varian's pre-op unit, which is the planning cockpit.
So now what they've done is that they don't send a Varian separately. If you want to buy a Varion today, you can't buy a Varion separately. You have to buy an Argos to be able to get the advantage of a Varion.
Right. So I think what Sir was trying to say was whether the Argos can be linked to the Callisto system of the Zeiss. I think you.
The Callisto. Argos can only buy the
parameter, correct.
And not the
Argos, as he's saying, Argos can be linked to the Varion system, not to a Callisto system.
I think you cannot link it. However, you can get the planning from the Argos and then manually put it in the Callisto. That can be done.
That can be done.
So
but the main this thing is that that unlike the Varion, which could be bought separately, if you want a Varion system, you have to buy the Argos.
Nowadays, yes.
No. And there's another one coming up after this, so that it never stops. Yeah.
That's the unity.
So I think that was a wonderful presentation. Thank you, Dr. Parul. So we have with us Dr. Anurag Mishra. So I think prolific surgeon, beyond the rings in presbyopia correction. All to you, Anurag.
Thank you, sir. Good afternoon, ladies and gentlemen. Greetings and regards from the land of Raj Jagannath. Now, when we talk about ring designs on the IOL, essentially we are talking about trifocals. And why do we look beyond the rings? This is a concept which has come very recently. Why do we have to look beyond the rings is because the ring design essentially causes this. You've got 3 foci of objects which produce 3 foci of images on the other side of the lens, starting from the nodal point. And when you are looking at one particular object, that particular focus becomes more prominent than the other 2. So we have 3 foci, one for distance, one for intermediate, one for near. And when you're looking at a near object, for example, the other 2 foci become relatively blurred, but they're still existent. So 3 distinct foci will give you crisp vision for 3 different distances, but all these 3 foci will be active all the time, irrespective of where you look at. That was actually the reason for which the concept of EDOF, or extended depth of focus, came in, which essentially turns the focus into a line. Now, according to the definition of US FDA for EDOF, you have to have the focus in the form of a line, and it has to offer a defocus of minimum 1.5 diopters for that lens to be categorized as an EDOF. Right. So to combat that, the ring design, there were 2 things that came in. One is obviously the monovision, wherein you put in monofocals in both eyes and render one of the eyes myopic so that it gains near vision. The other was a fusion or paired approach. The first paired approach came from a company called Acritec, and the lenses were called Acritwin. Interestingly, they had brought out lenses both in single piece and multi-piece designs. Both of these were multifocal IOLs. However, the design differed in the sense that they had 70-30 ratio. One was 70% dominant for distance and the other was 30% dominant for distance. So both the eyes getting both the IOLs will get multiple foci. However, one eye has a distant dominance and the other has a near dominance. The other paired approach that is there in the market is the Geometric and the Geometric Plus coming in from Hoya. Excellent IOLs. I think Anaga is going to speak on it later on. But they have a variation in the step height, which differentially distributes the light according to 3 different distances. The combined platform that I'm going to speak on is actually called the Well Fusion technology, which has recently been launched from the house of SIFI, coming in from Europe. This particular paired approach is based on EDOF IOLs on both eyes. So both of these IOLs are EDOF IOLs, but how they play around with this is with the means of spherical aberration added or subtracted. Now these lenses are called the Mini Well and the Mini Well Proxa, both of the IOLs. Let's talk about the Mini Well first. The Mini Well has 3 zones, as you can see here. One is shaded green, which is near dominant. The other is a peripheral girdle of red, which is spherical aberration subtracted from the central zone. The central zone's 2 millimeters in diameter. The peripheral girdle, the immediate peripheral girdle is 1 millimeter, where they have added on negative spherical aberration, and then the broad peripheral zone of 3 millimeters, which again has positive spherical aberration added. So what it means is the central zone is near dominant, the red zone accounts for an intermediate, and then the peripheral zone is dedicated towards distance. Now the Proxa, on the other hand, has 5 zones. The central disc is for distance, so distance dominant. Then there are 2 zones, and there are 4 zones alternately dedicated for intermediate and then for near. So the difference between the 2 platforms is the optical zone, the active optical zone with the Mini-Well is 3 millimeters. It's 5, the zones are 3 in Mini-Well, the zones are 5 in Proxa. The active central area is 3 millimeters. With the Mini-Well, it's 4.5 millimeters in Proxa. And then the focus lies at 40 to 45 in Mini-Well, which brings in further closer to 30 to 35 with the Proxa. So again, I would like to emphasize on the fact that both of these are EDOFs, both of these are line foci, but the focal distance it offers clear vision at is 30 to 35 in case of Proxa and 40 to 45 in case of Mini-Well. So what essentially it does is effectively, it gives us the, oops, sorry. Somehow it's getting stuck in here. Okay. So it's essentially giving us the add power from 1.5 to 3.5 millimeters. Again, both of them being designed on the EDOF platform, none of them having any rings in their design factor. Talking about the material, it's a copolymer. So it's not a pure hydrophilic, it's a hydrophilic and hydrophobic combined, high refractive index. It does get in 2.2 millimeter incisions. However, there is a slight amount of blinker in that. I'll just speak about it in a minute. It has a double square edge and is preloaded, which keeps us away from the contamination principles. The only case wherein I would, of course, when you have designs like these, you're not really concerned about the alphas and the kappas because you have a central 2 millimeter zone, and I've hardly seen anybody's alpha going beyond 1 millimeter. So it's actually not a concern. What is a concern though, since you're playing around with aberrations, both spherical, positive and negative, the MTF curve drawn from the cornea preoperatively is something I always look at before I give any IOL that plays around with a spherical aberration. Look at this patient, for example, and the cutoff mark for me is a 0.4's value at 10 cycles per degree. If the value drawn from the cornea is beyond 0.4 at 10 cycles per degree, that patient is a suitable candidate. Because the MTF drawn from the internal plane, which is a cataractous lens, will always be low. We know that. But the corneal MTF, the corneal contrast should be good. This patient, in contrast to the earlier patient, which has a low contrast sensitivity already, the MTF is bisecting this critical square, will be designated as an unsuitable patient to me to receive any IOL that plays around with spherical aberration to impart depth of focus. The other blinker, as I said, since it has a tetraport haptic design and the haptics are a little broad when they fuse with the optic at the time of implantation, they at times just topple over, they flip over because there's a resistance coming in from the CCC margin. So if they topple, there's nothing to worry because the overall diameter is not much. It's 11 to 11.25 millimeters. So with the same irrigation cannula, I can just go in and with the second instrument can flip it over before guiding it into the bag and keeping it there. So nothing much to talk about in the implantation technology. It's quite smooth. The material's good. And I don't have loads of experience to share with you with regards to how the patients behave post-operatively, but whatever limited experience I've had thus far, it's behaving pretty well in my hands. The only thing that is a concern at the moment is the proxa, which goes into the non-dominant eye according to my principles, does not have a toric trim at the moment. So I just hope they bring it out soon to the market. Thank you so much for your attention. Only if both of the eyes allow that principle to be operational. Sometimes they don't. Then the mini well goes in both eyes.
Dr. Narag, interesting presentation and very interesting concept. So I was just wondering, the proxa, which has more zones, 5 zones as you said, probably may have a lower contrast compared to the mini well.
Yeah, that's the reason why.
Yeah.
It's not about proxa, it's not about mini well, it's also true about VVT, it's also true about any IOL that is basically working on the EDOF platform. The VVT, of course, doesn't play around with the spherical aberration, so it's a safe IOL to be put, even if the contrast is low to start with. But any IOL that has even a minimal amount of spherical aberration added, we should look at the preoperative contrast sensitivity coming in from the cornea. If it's low, it should not go in because it's going to reduce the contrast even further post-operatively. So you're right, yeah.
So before we take on Dr. Gaurav Mishra, and he'll be talking on beyond distance with advanced monofocal IOL, just a quick question from you, Anurag. For the minival proxa, do you feel the dysphotoptic symptoms a little more as compared to the minival?
Yeah, so the paucity of time actually prevented me. But the other thing that I should always look at, I would always look at, particularly when it comes to the proxa eye, is the preoperative pupil and the preoperative mesopic pupil in particular. So if the preoperative mesopic pupil is more and it's large, then I would stay away from it because, as you rightly mentioned, sir, it has more zones and the dysphotopsia is likely to be high if the pupil size is high. But if the pupil size is somewhere around 3 to 3.25 millimeters preoperatively, and we always look at the pupillary size both under mesopic and photopic conditions, then there's no issue. But what you're saying is right. Dysphotopsia is bound to be a little more as compared to the mini well eye and to the other IOLs as well.
So in your experience, those hypercritical patients who are driving and young, are they candidates? And what has been your experience?
No, that in itself, by itself, as a standalone is not a contraindication, because the photic phenomenon that arise from these IOLs is not as bad as you would have them from a full optic multifocal IOL, because they don't have steps. So the step dysphotopsia is always more. That's always more distressing and disturbing. This is not as bad as that, but still. So driving is not a contraindication, but if the pupillary size is large, I'll just be on my caution.
Thanks, Anurag, for that wonderful talk. All to you, Dr. Gaurav.
Thank you and good afternoon, everybody. So I'll be taking you through a small journey that is beyond distance with advanced monofocal IOLs. So first and foremost is, I stand here at the tail end of the journey to different IOL choices. This work will be a genuine nature walk. Please bear with me for some time. Sightseeing the IOLs in the natural, uncommercialized settings, its research in the walled garden of buzzwords like premium and freedom, whether they be multifocal or EDOF lenses. So my goal is to climb over the wall and take you behind two different IOLs. Why I stand here is a question. Nothing newer and flashier IOL makes sense until you understand the monofocal IOLs. Monofocal IOLs are the anchor to the lineup of the IOLs. Monofocal IOLs focus and covers a lot of range from moon to 20 feet away, equally and sharp. The quality of optic translates into how sharp the distance vision can be. Isn't it magical? Have you seen the telescopes or microscopes or cameras being multifocal or EDOF? Have you ever wondered? Monofocal IOLs are unparalleled in simplicity, clarity, and focus. That is why telescopes are monofocal, not multifocal. Companies describing monofocal IOL as standard government-issued IOLs that gave a negative reaction to the monofocal IOLs. But this is a technological marvel, whether you believe me or you do not believe me. Monofocal IOLs are simple, secure, and reliable. Saregama is still popular, though many musical soaps have come and gone. Monofocal IOLs are still the most consistent, most popular choice worldwide, despite other options, because they are tried and true and just keep getting better. In India, people don't need wide borders. The IOL they need with the best possible vision is here. That is the Clarion. This is the next generation advanced monofocal IOL. It has an optical clarity, precision edge design, functional intermediate vision, refractive predictability, rotational stability, and enhanced delivery system. So optical clarity. In a study done in Japan, patients were followed up for 7 years, one eye with Clarion, the other with Microsoft IQ. The surface light scattering was significantly lower in Clarion, while it increases with IQ. In FDA registration study, 350 eyes implanted with Clarion were followed up for 1 year. No IOL were observed with glistening or surface light scattering. No glistening and surface light scattering reported in a study done by Oshika et al. From 1 to 9 years. Edge design. It has a low PCO rates for the clarity that lasts. Clarion IOLs have low PCO rates, reducing the risk for an additional procedure. The Clarion IOL features a precision edge design that helps guard against the PCO and minimizes Nd:YAG rates. Clarion IOL continues a low Nd:YAG rate as of FPSoft lenses, less than 1.5% at 1 year versus 2.2% with Microsoft IOLs. And this is the precision edge design, which is the proprietary edge curvature that diffuses the light that is reflected from the edge of the lens. And the functional intermediate vision. This functional intermediate vision, if postoperative refraction comes out to be between plus 0.5 to minus 0.5, the patient can still have a 20 by 20 vision at a distance. You can see this graph, there's a broad landing zone. This partially corrects the positive corneal spherical aberration with an optic design of minus 0.20 micron spherical aberration. And it delivers a crisp, sharp distance vision without compromise. And a functional intermediate vision with Clarion is just a bonus. This functional intermediate vision is 82 to 9.9% of patients with Clarion monofocal optic design achieved an uncorrected intermediate visual acuity of 20/32 or better. Refractive predictability. This design, which you can see in the circle, is a unique haptic optic junction design. It absorbs the energy from the capsular back compression without transferring it to the optic. And it allows the IOL optic to remain stable. It improves the refractive stability by providing superior axial stability, tilt, and centration. This is a small video which shows that with the contraction of the, you can see with the contraction of the capsule, the optic haptic junction contracts, but not the IOL. That doesn't shift from its normal position. And same here, you can see with the contraction of the capsule, the other lenses may be pushed forward, but not the Clarion. Rotational stability. Exceptional rotational stability results you to expect from the very beginning. Fibronectin bonding of the Clarion, similar like Acrysoft, provides rotational stability. You can see in day 1 and 6 months that only 22 degrees of the mean rotational stability with Clarion. In my own experience, the growth of Clarion has gone up as compared to IQ and Ultracert. In my practice, IQ and Ultras have taken a back seat now. So the material, you all know it is a hydrophobic material. It is dry packaging, water content, and refractive index is 1.55, and glass transition temperature is 9.1. Clarion autonomy, which is the latest in the armamentarium, is the preloaded having a Clarion monofocal IOL. They have other things also, like the monofocal IOL, toric IOLs, as well as wagon wheel. All the other lenses of Clarion, like toric, EDOF, and trifocals, is a non-preloaded option. This is a small video showing the implantation of this lens. This is the packaging that comes. You have the guard, and in the distal part, there is this carbon dioxide cylinder. And once this is the port from where you insert the OVD. It goes up to the tip. And after that, you remove the guard.
Dr. Gaurav, you'll have to run through. Yeah.
Oh, just 1 minute, not more than 1 minute. You just remove the guard. Just push the lens and it goes inside. Thank you so much. And I would invite you all to the UP conference, which is being held in Meerut on 29th, 30th, and 1st of December, and all of you are invited. Thank you so much.
That was a wonderful talk, Gaurav, and we hope all of us should be there in Meerut with you.
Thank you so much.
With the kind of hospitality that you are putting up. Congratulations in advance, and all the best. So now we have another prolific surgeon from Gujarat, Dr. Shel Vasavada, and back-to-back ASCRS AO film winners. So all to you, Shel. He'll be talking on the new generation patient-friendly EDOF lenses.
Thank you so much, sir, for the kind introduction. We do receive research grant support from Alcon Laboratories. I think the biggest drawback or biggest reason why most surgeons hesitate to implant multifocal IOLs of any kind or any brand are that they are worried that which is going to be that one unhappy patient which is going to, spoil their mood for the rest of the next few months. And therefore, everyone is looking at other options except for IOLs. However, I must say with the newer generation trifocal IOLs, these symptoms are far less than what they used to be before. But not all patients are suitable for trifocal IOLs for various ocular and non-ocular reasons. However, all patients, irrespective of their background, rural, urban, they believe cataract surgery is their chance to be independent of glasses after the surgery is done. With increased life expectancy and with UPI and digital India, phones and smartphones and screens have taken over everywhere. So what is an EDOF lens? So there are so many nomenclature, monofocal plus, pinhole, this, that, etc. So the FDA has made certain guidelines, and to simplify it in simple language, what it means is that an EDOF lens must have at least more than one line improvement in intermediate and near vision compared to monofocal IOLs in more than 50% of eyes, and it should not be inferior to monofocal IOLs for distance vision. This is a very striking line to understand, that when an IOL does not fulfill this criteria, so not even one line improvement in intermediate and near vision, they do not qualify as EDOF lenses. So any IOL which is labeled as a so-called monofocal plus is not going to consistently give you more than one line improvement in intermediate and near vision in more than 50% of eyes. Otherwise, they would have got the label of EDOF IOLs. And there have been now several articles in literature to suggest that the near vision is significantly better with the EDOF IOLs compared to the monofocal plus IOLs. The advantage of EDOF IOLs is that they are free from dysphotopsia and all the other issues related to it. The drawback, however, is that they are not the IOLs for someone who doesn't want any glasses. So they do need reading glasses, particularly for fine print. And there is a marginal loss of contrast in dim light, although it's not clinically significant with most platforms. So this is a 56-year-old male, a senior manager in a factory, a few kilometers. So Ahmedabad is very industrial, but it's outside the city, about 30 to 60 kilometers from Ahmedabad. He's myope, and his main concern is glare while night driving. He now has cataract. So his activities are, he needs supervision of field force as he's the manager. He checks daily logs, and he drives back to the city through country roads, which are single lane roads, no dividers, and therefore headlights. He wishes less dependence on glasses, but doesn't want to have compromise in driving back home and going for day on and day out. So glare and night driving being his primary concerns, trifocal IOLs were not suggested, and we suggested a bilateral vivity with a target emetropia because driving is important for him. We explained that he will need glasses for fine print reading. Fortunately, he had an excellent outcome binocularly with a good binocular intermediate and near vision of N8 comfortable. When we stretch it with extra light, he does read N6 in the clinic. However, we do know that this is not the real life scenario of N6 with the extra light. He's able to drive comfortably on his own. That was his primary concern. He finds that his reading vision is fairly good, including he's increased the font size in his mobile. So he's able to manage that and the headlines basically of the newspapers. He does use glasses selectively while cross-checking bills and accounts, and uses a 1.5 diopter reader for that. So in short, for night drivers, this is a good IOL. 64-year-old lady actively does stock market trading analysis on her desktop. Her husband is suffering from chronic illness and mainly bedridden. She is the one who's running the house, very well to do. Two children, both stay abroad. So she is taking care of the husband and the family. Cortical cataracts, keen on spectacle independence, but does not want to compromise on the quality of her vision, as she is the main person here in India running the house. So we discussed the option of bilateral vivity toric, as she had astigmatism. We said we'll target one eye for emetropia, and based on the outcome, let's see if we can do something for the other eye. So this was her first eye, where we planned an IOL of 24 diopters, and fortunately she did turn out quite well for distance and quite good even for intermediate and near. In the second eye, normally I would have chosen a 22, but I bumped it up a little bit to 22.5, which is a minus 0.5 diopter target. She is now comfortable for almost all activities without glasses, distance, intermediate, and near. We did our randomized clinical trial, which got recently published in JCRS, comparing two groups of bilateral emetropia and mini monovision only up to minus 0.5 diopter, not more than minus 0.75 diopter. And what we found was that the good part was the binocular distance visual acuity was not compromised even in the mini monovision group, and the intermediate and near vision was significantly better in the mini monovision group. However, we had equal number of patients who said they didn't need glasses in both groups. Coming to another case of a 73-year-old gentleman, bilateral cataract, retired but very active. On ocular examination, he has fine ERM and therefore not a good candidate for trifocal IOLs. And therefore, we suggested the option of an EDOF IOL, keeping in mind the positives of less problems in the quality of vision with an EDOF. We discussed the option of target emetropia for him, and he's very happy. He uses around 1.25 AD for fine printing. So even for fine macular pathologies, it's something to consider. An 83-year-old female, she's 8 months she stays in Canada, 4 months she comes to India, and in Canada obviously she's housebound, addicted to iPad and Sudoku, and because of her nuclear cataracts she's not had to use any reading glasses for the past several years. So demanding lady, very active. Unfortunately, on posterior segment examination, she has dry RMD and significant drusen. So that was a deterrent for us to suggest a trifocal IOL for her, because near vision was her main activity. So we discussed that unfortunately trifocals is not a good option. We'll consider bilateral vivity. You may need, we explained that you can use extra light on your iPad and otherwise, and you will need glasses for reading, and probably even for your iPad, we are not sure how it will turn out being dry RMD. Fortunately, she did very well, and she's N8 unaided for near binocularly, and she's able to manage all her iPad and her reading and games and Sudoku on the iPad without glasses, so she's extremely happy. So I think the EDOF IOLs, the newer generation Vivity, with which I have good experience with, has a good quality of vision for definitely distance intermediate, and very good functional near visual acuity for most daily tasks. It's been having shown to have good outcomes in healthy eyes, but I think now we have found that stretching the limits to mild comorbidities like early glaucoma, post-LASIK, ERMs, dry RMD, early dry RMD is something that is of use. Do explain to them that they will need reading aids for fine print. That's something that you cannot get away with in EDOF IOLs. There is some loss of light for near activities, so if you ask them to increase particularly the contrast and brightness of their phones or tablets, that will really help them to be independent of glasses even for near. But it is not for those who don't want any glasses for reading. Maybe for them trifocals are the best IOLs. But this definitely stretches and increases the range of patients in which you can use presbyopia correction. Thank you so much for the patient listening.
Wonderful talk, Shell, and I would second that, yes, Vivity, specifically in EDOF, are the lenses of choice in cases of comorbidities, except one post-hyperopic LASIK. I think that has been a very burning topic here. So I think, yes. So thank you, Shell. So now I invite Dr. V.C. Mehta, and I think he'll be talking on trifocal lenses to improve the quality of life study results. So I think moving from modified monofocal to EDOF and now to trifocal lenses, I think all to you, sir.
Oh, thank you. Good afternoon, all of you. I'm going to digress a little bit from the technology talks and go into something which is health economics. So most of the time when we work up with the patients come to you for a counseling, and the most important question they ask is, which lens should I go in for? And the premium lenses usually have a very high cost, that is the highest kind of a package. And the next question that comes to the patient's mind is, what is the benefit if I spend so much of money? But quite often we are unable to convey the exact amount of benefit that the patient is going to have. And instead, quite often we talk about halos, glare, reduced contrast sensitivity, etc. So here we indulge in a study which is going to quantify the benefit that the patient is going to get in case the patient opts for a bilateral panoptics versus the bilateral monofocal lenses. These are the disclosures, and how the study was done was we took into consideration the quality of life, the lifetime cost involved in bilateral panoptics versus the bilateral monofocal, and willingness of a patient to pay. Now, you can measure the quality of life, and quality of life measured in quali years. That means one quali is equal to 1 year of perfect quality of life. And for us, as far as the cataract is concerned, the quality of life is based on the need for glasses for daily activities, visual disturbances like glares and halos and starbursts, or adverse surgical outcomes. So we put all this into one, and then we decided to run the model. So over the period of time, we estimated following things, that is quality of life improvement from each IOL, expected lifetime cost of each IOL, and incremental benefit of PanOptix compared to a monofocal IOL. And this we decided then to find out what is the quantification of quality of life and what is the net monetary benefit. These are the things that we added into the model. The cost of procedure, about 1,10,000 for a PanOptix, 45K for the monofocal. Cost of glasses per year, in PanOptix you hardly need glasses, but in monofocal you need either the patient gets a reader's distances, bifocal or progressive. We also included the visual disturbances, capsulotomy, etc. And then we calculated the quality of life. The quality of life gain in a monofocal IOL was 6.12, while in a PanOptix bilateral was 6.45. That means the quality gain of 0.32 more in a PanOptix IOL compared to a monofocal IOL. Now, this against this, the lifetime cost of glasses is definitely significantly low in a PanOptix IOL, while it is about 35K for the rest of the life for the monofocal IOL. So here now the patient can understand that I am getting a good quality of life, and at the same time I am kind of paying little more initially, but I not end up paying continuously for the cost of the IOL. So the high cost-effective treatment for cataract patients. So lifetime additional cost of bilateral PanOptix is 224, while that of the monofocal is 129. Now the difference is around 95,000. And for that 95,000, they get a quality of 0.32. Now, the patient can kind of spend this much of money? So we went back to the WHO standards, and it says that the threshold for willingness to pay for a quality of life gain of 1 equals around 1 to 3 GDP capita. That means Indian GDP, if it is counted in PPP, it is around $8,000, and these are around 6,09,000 rupees, whereas for one quali gain they are paying 2,95,000, quite less. So it is very effective, it is very cost-effective treatment strategy for a cataract patient in India, and it is ratio is definitely much below than the WHO recommended standard. So PanOptix provides a good, this is the only IOL which can genuinely make the patient spectacle independent. So if you have worked up the patient very nicely and thoroughly, then you can definitely suggest this IOL for the patient. So to give a conclusion to the patient, I tell them that a bilateral PanOptix will incur a one-time high cost, but a lifetime monetary benefit of not having to spend for your glasses, and a lifetime of improved quality of life. While as a bilateral monofocal IOL, the first cost is going to be the less, but lifetime recurring expenses are going to be more, which when added up, which will much more than a bilateral PanOptix IOL. And at the same time, there will be a lifetime dependency on glasses for every activity that you do in the nearby. Now, when you explain this to the patient, a lot of patients are willing to go in for a trifocal PanOptix IOL than a monofocal IOL. So I hope that this kind of a study helps us to come across better to the patient in kind of selecting an IOL for themselves when a cataract surgery time comes. Thank you for your kind attention.
I think, Dr. Mehta, that's a wonderful workup that you have done. And I think if this is circulated to the entire All India Ophthalmological members, I think this could help in upgrading their practices. What is the average expectancy of life that you had taken in this?
So that depends on the WHO, this thing,
Because
and maximum we had counted up to 20 years.
Because most of the patients end up saying, Doctor Sahab, 2-3 साल ही तो जीना है.
हाँ वो बराबर है, लेकिन अच्छी तरीके से जीना है.
Thank you very much, sir. That was really a wonderful calculation, and I think that will be a game turner for the trifocal IOL. So now, next we have Dr. Ajay Sharma, and he'll be talking on get the best in both worlds, focus near through far with CRV technology. All to you, Dr. Ajay.
Good afternoon, everyone, and thanks AIOS to giving me the chance. And I'll be talking on the focus near through far with CRV IOLs. As we all know, we just have been talking, and we know how rapid the change is for the near vision demands, and so is the change in the need for the continuous range of vision. With various lenses, what I think we have been talking and we all know about are the multifocal, trifocals, and extended range of vision, but they all have some sort of a flaw. Now, for multifocal, there is a problem with the intermediate vision. For trifocals, there is a loss in contrast, higher incidence in halos and glare is there. And extended range of vision, definitely there is a problem of the near vision. Now, what do we do? Now, this is a technology which comes in, which combines and leverages the benefits of both the ERV and the multifocal or the trifocal technology. That is a continuous range of vision without drop or fluctuation, and there is a higher spectacle independence, just like a trifocal, along with a higher contrast, just like a ERV. So we are combining these two changes here, and we all know the LED, what role it plays now, and LED gives basically the emission of a shorter violet wavelight is there, and this technology blocks these high energy violet wavelengths and improves the driving vision quality, which everyone is afraid of. Whether shall I put these lenses in a patient who wants to drive? Just to show the focal range, the wavefront, how the wavefront is created in the monofocal. You can see this is just for distance. For the bifocal or the multifocal, this is the 2. And for the trifocal, you have this, but here intermediate is compromised. And continuous, again, the near vision is compromised. So here are the lenses. This just to show, this is the lens which gives you a continuous range of vision, and which is for the near, intermediate, and distance. Now, this lens is the Technis Synergy. It's a breakthrough innovation, and it gives a continuous vision across the range and empowers patient to see all their distances. It is a superior low light contrast also. Patient can see in all day and night. Design is just like if you see a simple Technis lens, and then there posteriorly it has the posterior diffractive surface. It has around 15 rings here. The overall diameter is 13 mm, and the posterior, the continuous 360 posterior square edge is also there. So all the similarities to a Technis which we all have implanted, it is there, and that there is the posterior side also haptic offset is there, 3 points for the 3-point focusation. And now astigmatism again is very important, which we all know, and without this no lens is complete. And we have Synergy CRV also available in toric with the Technis Toric 2 platform. Now, as I have said already, it combines these two technologies, monofocal, multifocal IOL technology that delivers good distant and near vision and pupil independent design, and Technis Symphony, which is a continuous range of vision. It has limitation in the near vision, which can be done by the multifocal part of it. It has a chrome aligned technology, and it is a pupil independent design. Just to show the defocus curve, how nicely you can see this, And this is going to tell you why, I'll be telling you why to choose biometry which is either emmetrop or towards the hyperopic side, because you can see it is slightly myopic, one line, and it is slightly hyperopic. This is decrease of just 0.5 line. And throughout you can see even near vision, the 33 centimeters patient can read. Clinical pulse, I think this is more important rather than getting into the technology and what all is, it is all written there in the books and literature. So this is that minimize the post-operative residual astigmatism, because if we have to do it a normal lens, plano lens, then give only, it has to be less than 0.75 diopters, and no autorefs, avoid patient with corneal abnormalities, manage the dry eyes and all these situations prior to the surgeries. Ensure post-operative patient for the adequate expectation, you have to tell them it's going to take 4 to 12 weeks to settle down, and avoid pre-existing ocular conditions, especially the retinal conditions. A constants, again, it has its 119.3. If you are toric, Technis A constant can be used. Most, if all are using that. Multifocal IOL A const, personalized A constants should not be used. And select the IOL power that gives the residual refraction closest to plano or it towards a hyperopic side, not to a myopic side. This is just to show, I have emphasized more on it because we did that initially, and the company tells we did that. Few doctors did a myopic side and they had problem with the vision. Finally, when we did this emmetropic or little hyperopic, then we didn't have any problem with the vision. How do I choose my patient? Now, this is just to say, like, this is certain instances I'm showing that how I chose my patient. 52-year male patient, IT professional, bilateral cataract, works on all devices because wants a near vision, also plays golf, drives at night. So we gave the synergy and patient is happy. So similarly, patient household activity, female patient teaches children social activities, cooking, playing board games, cards and all. So we implanted this, and this again, very interestingly, 50-year patient which is myopic and presbyopic, fed up with contact lenses and glasses, wanted to get rid of glasses, where we did a refractive lens exchange, bilateral synergy, and patient was happy. Now our experience till date, we have used around 1754 lenses, synergy lenses, normal as a toric. This is some study which we did in 164 eyes where 42 bilateral implants were there. It was a retrospective study, multicentric, 7 centers were involved, and these were the results. Very good results as far as what we wanted to see in the in these type of lenses. Or day 7, the 6/6 vision was 106 and 1 month, 130, 6/9 was around 22 after a month, and similarly near vision you can see is, this is what we want to show. After 1 month, 134 patient had N6 and 28 and 8. Nearly 96% had a good vision post-operatively, and intermediate vision was good, which has to be there in patients. This is just to show the data, the depiction here. Halos and glare, everyone is worried about that. We were also worried about it. We found 21 patients complained of this, and out of that 12 patients improved with a period of 12 weeks, and 9 patients they still complain about it. And just to show the implantation, it is just similar to anything. This is just the lens, and this is how it looks like. Loading can be done as you implant a Technis lens, nothing new in that. And after the loading, it is just the, it goes in, the cartridge goes inside the injector, and you can implant the lens very nicely in the eye, and just like a Technis lens. So implantation is very easy, no itch, no problem. You can see the lens is very well centration post-operatively, else you can center it nicely post-operatively with whatever way you are doing. And Torvik, I'll skip. Now just a few, 1 minute for the tips and tricks of a successful surgery. Pre-operatively and per-operatively. Pre-operatively, set realistic patient expectation. Strong desire to be independent, independent with a spectacle for far, intermediate, near. That is again, and chronic grumbler should be avoided. A positive attitude is needed. And counseling is very important. Whatever you do, whether you do a femto or a phaco and whatever lens you are using. You have to tell the patient whatever you want to do. We give this charts to all the patient to show whatever.
Dr. Ajay, can I request you to please conclude?
Just finishing. So what patient is doing, what activities, and again, peroperatively, the incisions have to be perfect, because if they are not, then we will induce astigmatism, and that can again cause problems. Similarly, rhexis size and centration has to be proper, because if it is not, then if a decentered lens, a lot of decentered lens can create a problem. And so for this, you can either use your CCC or you can use a femto, and these are certain things which you should keep in mind. And in my experience, spend good time preoperatively with your patient, understand their lifestyle, need, and help them taking a decision. Always under promise and over deliver. Use your words wisely. Replace terminologies like no need of glasses to reduce dependence on glasses. Thank you very much.
Thank you, Dr. Ajay, for that wonderful overview of Synergy. And I think it's one of the very nice lenses delivering high quality distance intervision near. A quick question to you before I just introduce Dr. Sudhir Srivastav, and he'll be talking on demystifying monofocal plus IOL technology. So in your study, you said almost 22 patients were 6'9" for distance uncorrected, and similar patients had those dysphotoptic symptoms. So do you correlate that it was because of that residual refractive error that these patients had those kind of?
Most of the patients, yes, they fell into that category only, wherever they had residual refractive errors. So most of them who were probably 6'6" and all that, very less percentage of patient complained of that.
Wonderful study. So all to you.
Okay, do you plan to correct the residual refractive error?
It depends on the patient. If a patient is happy, because here we are talking about the distance, near and intermediate vision. The patients who are happy with the near vision and the intermediate, they might not be needing again a 6'6", and if we have it in the first eye, we are definitely going to do something for the other eye.
Because I have a feeling, because if you correct the residual refractive error, the halos and glare might be reduced significantly.
Yes, but totally agree, but here we didn't try in this particular study.
Yeah, I have done a couple of corrections, LASIK corrections after this, because sometime in initial cases we got some surprises. So yeah, definitely the glares and halos we can reduce. Good afternoon, everyone. First of all, thanks to AIOS for having me here. Today I'll be discussing about the demystifying monofocal technology. From the beginning of this session, we are listening about the technologies, and very interesting study came in 2020 from Japan, and they basically evaluated the patient's sleep index and the happiness quality and the happiness index. And they found that the patients with posterior subcapsular cataracts, they are the most happiest patient after cataract surgery. And now we are evaluating the same thing, and we are getting that monofocal patients, they are the happiest patient after the cataract surgeries. And despite the fact that still we are implanting 94% patients are monofocal, but monofocal remain monofocal till we got some innovations in abrasions. We recognize the abrasions. So it remained poor man's IOL. And when there was a change to shift from hard to soft, because now we started doing phaco surgery, so there was a need to get a lens where we can implant through a small incision. So the foldable came, then abrasion-free surfaces came. When we started recognizing the spherical abrasions to nullify them, we'll get a better quality of vision. And approximately 6-7 years back, then the concept came that we can even modify this lens, the surface, we can play with the abrasions, and we can create some defocus from the distance without compromising in the distance quality, and we can offer some good quality of intermediate vision. So now quality of vision is not visual acuity, because it's 180 years old system. Now we need to understand about the contrast and aberrations also. Tons and tons of studies have come up. They compared the monofocal with multifocal lenses, and now we know that they stated that definitely will get a better uncorrected visual acuity with multifocal lenses, and we get better spectacle freedom after multifocal lenses. But they come on the cost of what? They come in the cost of halos and glares, because if you have segmentations on the IOLs, you'll bound to get the halos and glares. So now we understand about this diffractive technology, that despite your counseling, despite your, you assess the patient's realistic attitude, you need to face the problems with glare and halos. So again, there is a shift to change back to the monofocal. Now we are stressing more on the enhanced monofocals. The brand leader in this concept, was the IOLs. It came around 8 years back, and with the concept they have, without compromising the distance one, we started offering the intermediate vision. Then the different companies recently, the Hoya and the IOL Isopure, they have even improved the technology. They have created better surfaces to offer the better intermediate vision. And as Dr. Vasavada has shown one study that they evaluated the Vivity, I think, implants with the mini vision. Again, the study came from J&J. They evaluated the monofocal with the if we offer the emetropia, and if we make this slightly, monovision, slightly, if the patient make the one eye slightly myopic, they are the happy patient in comparison to the bilateral emetropia. And again, no loss in the distance quality of vision. Another study came where they evaluated the 3 brand leaders, the IOLs, Impress, and the Isopure. They found in the Manuwaki study that they found that all the 3 lenses are more or less comparable, and the same way we are also getting the same kind of results. Interesting presentation as Dr. Anurag has shown about the MTF values. In this case, the patient came around, I think operated it around 2 weeks before, and the patient was having a multifocal lens in one eye, very happy patient with 6/6 vision and N6 vision on the Snell lens in the evaluation, but patient was complaining about the photic phenomena because patient was young and during driving, he was facing some problem. So we discussed with the patient, and then we implanted the monofocal lens of the same company. Patient got good 6/6 vision with N10 without glasses, and patient was improving with 1.25, 1.5 improved to N6. And because of the contrast loss, if you see the maps, yeah, you can see that, Dr. Anurag, you can see that the corneal MTF value is excellent in both eyes. And in the right eye where we implanted the enhanced monofocal, you can see that there is a less dipping, and it is away from the square. And in the multifocal lens, there is a dipping, and this is the reason because of the contrast loss. So in our study, we analyzed the maximum, we evaluated the IOLs because we have implanted more than 2,000 of implants till date. And recently, we evaluated the Isopure 126 lenses. And in majority of our patients, we found that the addition required 1.5 diopters and 1.75 diopters. Contrast sensitivity, we evaluated on the Bailey-Robson contrast sensitivity chart, and we found that contrast were comparable to monofocal lenses, and photic phenomena again comparable to monofocal lenses. Similar kind of study, we evaluated the Impress. We evaluated around 490 eyes, in which the 109 were bilateral implants and 381 unilateral implants. And again, the similar kind of evaluated. We have excluded the toric lenses in all variants because the torics were not available that time. And and we found the similar kind of result. The addition required were 1.5 or 1.75 diopters. So now we are living in the era where we need intermediate vision, and without any photic phenomena, without distortions of distance quality of vision. And especially now majority of us are presbyopic, and we can understand that we have to lift the glass especially when we going down the stairs. So it's very important to have distance intermediate vision. Thanks for attention.
Thank you, Dr. Sudhir Srivastav, for keeping it on time and a wonderful talk. So skipping on the line, we have Dr. Krishna Prasad Kudlu. He'll be talking on Ray 1 EMV. And meanwhile, I'll request Dr. Amit Garg to be ready on the other side of the podium. Thanks, Amit, for accommodating KP.
Thank you, Dr. Sonu. I'm really sorry, 2 o'clock, I only have to go and start the session in the other hall. That is why I requested. Respected Chairperson Shaw sir is also here. So I'll be talking about my experience with Renar EME. Excuse me, can you come and just help me out? Not moving. Yeah, they just escape. This is my acknowledgement. This lens collaborated with Professor Graham Barrett. So as we all know that natural crystalline lens has got a good accommodation, clear vision in the distance, clear vision in all lighting condition with a greater contrast sensitivity with a minimal aberration. So however, aging and dysfunctional lens does not compensate for the corneal aberration, but nowadays newer IOLs still correcting all this. So we started with PMMA, now we are in the aspheric model. So coming to the what should be the ideal monofocal intraocular lens, it should have a clear optical quality, uncompromised vision for distance. We should compensate for the spherical aberrations to the cornea, easy to implant, PCO protection, designing free and less inflammation. So which is the best intraocular lens model, whether it is hydrophilic or hydrophobic, still it is a question mark. Different type of EDOF lenses available in the market. I am not going to talk about the different lenses, but what should be the effective criteria as far as the EDOF lens is concerned? Depth of focus should be plus or minus 0.5 or greater than the monofocal control, 0.2 logmar. And distance corrected intermediate visual acuity compared to the monofocal lens, it should be always superior, which achieves 0.2 logmar or better than in 50% of the eyes. And best corrected distal visual acuity always non-inferior to the monofocal control. So how is this advanced monofocal really help? Because of the different type and also with the design, with the optic size, edge profile and haptic material. Always they say that posterior edge on the posterior surface of the intraocular lens that always prevent the PCO formation. Of course, PCO is probably the most common complication of modern cataract surgery. It should be a multifactorial depending upon the either surgical technique or IOL material. But dissociation of each factor is almost impossible, difficult to differentiate in our clinical practice. Of course, one or two words about the glistening, most seen in most of the hydrophobic lenses, less incidence with the hydrophilic lenses. But what problem happens with, because these are the fluid filled microvacuoles within the IOL polymer matrix, but although visual acuity is not affected, but the contact sensitivity is reduced so much. So coming to the refractive index, always hydrophilic will be better than the hydrophobic, because hydrophobic lenses has got a more dysphotopsia. Because hydrophilic acrylic lenses are more closely mimic biological tissue due to their high water content, that is ranges between 18 to 34%. That reduces the glare and aberrations. So what should be the ideal aspheric IOL? So ideal aspheric IOL is to return the eye to a youthful optic. The young eye has got always has got a zero aspherical aberration. So coming to this particular lens, yesterday I have done the live surgery also, EMV Renar. The advantage of this lens, it has got a aspheric anterior surface with a unique inner optic design. Always the most advantage, they induce the controlled positive spherical aberration in the center zone of the lens. So because of this blend edge, that reduces the longitudinal spherical aberration in this model. So because of there is no rings here, the reduced dysphotopsia for the patient. So normally what we can see, because of this increased spherical aberration, there is a positive spherical aberration in the center for the optic, there is a increased range of around 1.5 diopters in the emmetropic target, that we have to see. So normally patient need not have to wear the glasses for most of the intermediate lenses, intermediate vision. So coming to the other advantage, this lens, since it is a hydrophilic lenses, doesn't have any of the glistening, and we can even implant in the low silicone oil adherence, because after post vitrectomy also you can inject, since it is a hydrophilic acrylic material which has got with a low inflammatory response. So basically you can see here the advantage of this lens, average offset is only 0.08 mm 3 to 6 months after the surgery. So, and also it has got a 360 optimized PCO control on the posterior surface of the lens that prevent the PCO formation. Probably this is the only one lens, the injecting system available in the market it comes within the whole system within the saline, so that you can take out the lens. And always I used to wonder how Rayner can do this, because unless and until they are that sure of the technology, otherwise the chances of infection will be very high. But so far not even a single patient had come with any of the problem. So since it is a hydrophilic lenses, it goes quite easily within the bag. So my first preferred choice, if the patient doesn't want to wear the glasses for distance and near, normally I check for the dominant eye. Then normally for non-dominant eye, I make myopic by around 0.5 to 0.75 diopter, so that patient will have 6.6 for the distance when they open both the eyes and N5 for the near. This is about the injecting system. That's what I used yesterday. Straight away, like you take out the whole including injecting system with the lens, take out, put the viscoelastic within the small hole inside, then it can even go through 2.2 quite easily. And very, very easy to inject, and central channels are very good. It has come with now toric platform too. These are few of the studies compared with some of the other lenses available in the market, but definitely it shows a more advantage over the other lenses. So we have operated around 300 eyes with EMV, with the 50 eyes with the toric. Both the lenses have given exceptional results. More than 98% have got a comfortable monocular distance 6.6, and 95% are having intermediate vision N12 at 40 centimeter. None of these patients really presented with glare, starburst, halos at the end of 90 days. None of the patient had any residual toric refraction after usage of toric EME. Patients were fully corrected in the dominant eye and non-dominant eye, and made myopic by 0.5 diopter to gain the emmetropia. All 300 eyes were 95% emmetropic. In conclusion, these newer monofocal lenses are to be marketed as a premium monofocal lenses, as Ajay told in his talk. So they give a good intermediate vision and near vision. Added advantage of no halos, glare, shadows provide better results as an advanced monofocal. Rayner 1 EMV toric is a promising intraocular lens on the same rotational stable platform. I thank again my brother Sonu to give me opportunity to go a little early than other people, and you all invited to COSCON 2024, which is going to be held in Udupi. Thank you.
Thank you, KP, for that wonderful insight. I think this is one lens which is very close to your and Graham Barrett's heart. It's his product, I think.
Yeah. Because see, I've been doing this Press Beyond. I think Sheetal is also here. The same concept, how Press Beyond is working, similar kind of concept this lens is also going to work. So in the end, none of the patient, even when I'm doing Press Beyond, nobody complained any glare and halo, sir. They're not going to close each eye and see. So similar kind of concept I am putting in the IOL platform. The results are same only.
Thank you, KP. So next we have Dr. Amit Garg. Thanks, Amit, for accommodating KP, and he'll be talking on lock and visual performance with rock solid rotational stability. All to you, Amit.
Thank you, everyone. Thank you, IOS. Good afternoon. I will be talking about optimizing the performance of toric IOL. Cataract surgery has now become a refractive surgery where patient demands are increasing day by day. They are very high expectations. Astigmatism is pretty common and impacts the quality of vision. If we look at the literature, almost 1/3 of the patient have astigmatism more than 1.2 diopters. These patients may benefit from toric IOL, especially if we are planning for the EDOF or multifocal IOLs. Unconnected cylinder number may have the compounding effect. If one does not address the intraoperative astigmatism, almost 2/3 of the patients are left with astigmatism, and the quality of vision is compromised. The burden of astigmatism, we have seen the problems. Visual acuity is reduced, contrast is reduced, visual performance is compromised. Also, the financial burden of making glasses is an extra thing, plus the glare and halos bothers the patient almost 2 times if we have a cylindrical number in the eye. Another thing is reading speed is less in mobile and computers, and negative effects of glare and halos obviously affecting the traffic lights. Spectacle dependence is more. There is a chances fall for elderly patient if we give them progressive glasses. Astigmatism can be addressed with toric IOLs or LRI. In the recent past, toric IOL have gained popularity. The main challenge is rotation of the lens in post-op period. The maximum rotation is seen in 1 hour of the surgery. Thus, the removal of the viscoelastic is a very important step. Now, the Technis Toric is at the same platform as Technis. It has a squared and a frosted design, to which help us to make a rotational stability. It gives us stability because of this frosted design. Landmark study with Technis Toric has some highlights. It is based on the haptic design evaluation, as well as the few other landmark features which we take, the cornea pigmentation, corneal vessels, and pigmentation on the iris also. Maximum rotation is 2.17 degree at 1 week. 100% of the eyes had less than 5% of rotation in 1 week, less than 1% absolute mean rotation. We all have been using Technis lenses, and Technis Toric is also on the same platform, so that's why the optical quality and the rotational stability both are good. Technis is an excellent platform. Quality of vision does matter. 20/20 vision with sharpness, contrast is very important. Quality of vision, ability to see clearly even in low contrast conditions for your patients. And both the aberrations, chromatic and spherical aberration together, provides better quality of vision than simply reducing one or the other. Contrast is very good compared to other acrylic platforms. This is a glistening free lens, no glistening. Capsular phimosis is also non-existent, because capsular phimosis can cause decentration of IOL later on, and which further decrease the quality of vision. Technis IOL provides sharp quality of vision, minimize the scattering of the light, and obviously the decreased vision due to IOL decentration is also less. Now, the direct benefits of the IOL, toric IOL provides 94% at binocular uncorrected distant visual 20/25 or better. 88% of the patients achieve 20/20 monocular corrected distance visual acuity. 98% of the eyes achieve less than 0.75 diopter of residual refractive cylinder. Higher image contrast with Technis Toric IOLs. At night time, this gives a higher confidence because of the no glasses. And almost 97% patient want the same IOL in the other eye with the same surgeon. To sum up, it has all the advantages of the Technis platform and much superior stability due to frosted haptic design. I would like to take this opportunity to invite all of you on the 50th annual conference of UPACon at Meerut from 29th November to 1st of December. Thank you.
Thanks, Amit. That's a wonderful talk. And I think Technis 2 has really stood to that platform of rotational stability. Just a quick question. Meanwhile, Dr. Anaga is there. And I would request all the speakers to just, we have paucity of time, another 5 more talks.
Yeah.
So respecting time, I think. When do you take these patients for re-rotation, if at all you have to take? What is your, the day of re-rotation?
Day of re-rotation, at least I'll wait for like first day follow-up. If a patient vision is less, I just cross-check everything. And if that is the rotation is there, I will do that day only.
On the first day?
Yeah.
Okay.
Dissatisfied patient and is reading well, and supposing it's rotated even 5-10 degrees, will you like to rotate it?
No,
I mean,
not at all.
what is the
Never.
Just by seeing that it is rotated, will you rotate it?
No, sir, never.
No touch technique.
Depends on the toric trim we have put in also. In low torics, it will not matter much to T3 and T4.
Yes.
If you have put in a T9
Nine.
and it has rotated by 10 degrees, the residual to reciprocate.
But even then, taking patient to another OT procedure, then the patient is satisfied, I think I'll not do that.
Actually, normally they don't rotate by about 10 degrees generally, but about 5-degree rotation is there in some cases, and therefore it depends on the attitude and the basically acceptability of the patient. Patients sometimes also don't want rotation or re-surgery on the eyes. They said we are quite well adjusted to it. Maybe we might wear small correction in our glasses. So some patients are very reluctant to undergo surgery to undergo surgery a second time when they are slightly incapacitated and feel that they can compensate easily with glasses.
Sir, I think addressing the re-rotation on the day one would again, if the lens is prone to rotation, rather than taking a week by the time the bag has a little contracted and, then So I think taking by a week would be a good time for this. All to you, Anaga.
Thank you so much.
Day one rotation is required when you are totally flipped the axis. That's day one.
That is.
So very good afternoon to all of you. Thank you so much for the opportunity. So the challenges in multifocal IOLs today is patient selection. We can see since morning we have been having sessions on this. The number of choice that we have today is really huge. So you need to know which patient to use, what lens, good patient counseling and precise biometry and surgery. So what we do in our setting is a perfect biometry and readings to be taken on virgin corneas before dilatation, before applanation, ocular surface assessment, topography, OCT, macula, pupillometry and looking at the angle alpha. Regarding astigmatism, we always put in the K1, K2 on the Barrett toric calculator and let the Barrett toric calculator decide. There is no specific threshold as to 0.75 or 1 and we discuss all the options with the patient. We all know that like an ideal husband, the ideal multifocal IOL is really an elusive thing. So what we do is be a matchmaker. So you need to have a good communication with the patient, know what are his lifestyle choices, what are his visual expectations, and then discuss with him what options you are going to give. So what I do in my practice is ask 3 questions. How much of intermediate work? Now here we will be representing that with computer work, reading, and how much of night driving. Somebody who is doing night driving literally daily, I would probably avoid doing a trifocal. Even some of the ADOFs will have some amount of glare and halos, so I would safely go with a monofocal or an advanced monofocal. Now somebody who is not doing so much of night driving and glare and halos are acceptable, the next question comes to how much of intermediate vision represented by the computer work. So in these patients, you have to address this intermediate vision. So whether you are doing it with trifocals or with ADOF, you have to decide what works best with that patient. And whatever is the reading distance, that reading distance is very important. Also in those patients where ADOF you are giving for distance intermediate, remember to counsel them regarding use of a reader. Near addition has to be discussed, depends on what lens you're going to use. Do not overpromise them. Now this was an interesting study where they compared 5 presbyopia correcting IOLs, and I want you to look at the last column here where the near light distribution maximum is 33%. Now what if I tell you that you have a lens which has good distance, good near vision, preloaded, minimal rotation and minimal PCO? What we are talking about is the Vimenex Geometric family. So it has 2 lenses, the Vimenex Geometric and the Geometric Plus. What is the difference between the two? Let's see what is common between the two. First is the near ad is the same, 3.5, intermediate ad is the same, 1.75, and the central anterior 3.2 millimeter zone, which is diffractive. So in all these trifocal patients, not only your biometry, but your surgical precision is extremely important. Good centration of the lens. So this is a totally preloaded multi-cert technology, goes in very well with a 2.2 incision also. And you have to ask the patient to look at the light so that the centration is good, remove the viscoelastic from behind, and you have an excellent centered lens. Now this is how it is seen post-operatively. Important to look at here is the light purple line is the Vimenex Geometric, which gives excellent distance vision, and the dark purple line, as you can see for near, is very good. Now why is this, and why do we add these 2 complementary profiles? Is the first thing is both of these lenses have a very less loss of light. Now no matter what diffractive lens you're going to use, there has to be some kind of loss of light, but here it's minimum less than even 10%. Now this, I'll remind you of that comparison of those 5 presbyopia correcting lenses. Here you can see the Geometric Plus has the second order, that is for near as high as 38.6, which is probably more than anything else that you can expect. And for distance, the Geometric gives almost 50%. So you have good distance and good near when you combine the two. So you use Vimenex Geometric in one eye and Geometric Plus in the other eye. So somebody would ask, when would you use Geometric Plus in both the eyes? When would you use pairing? So we have used Geometric also in both the eyes with very good results. But definitely near vision is something which all of us want, with mobiles being high on the use. So this, the dark line that you can see is a defocus curve where Geometric is used in one eye and Geometric Plus in the other eye. So you have a very high peak for distance and a very high peak for near when you're combining the two. Now somebody who is, so for example, an 85-year-old lady who wants only near vision, so you can probably use Geometric Plus in both eyes or Geometric in both eyes where the patient is very happy with the first eye Geometric. So these are the lenses that we have used almost 200 lenses, but these were more than 3 months post-op results. So this was the distance, intermediate as well as near. All of these patients really did extremely well. These were our defocus curves. Now look at the peaks for distance, intermediate as well as for near when we have the combined approach. Minimal spectacle usage post-operatively. Now because they are diffractive, there were a few patients who had a little bit of photic phenomena, but they were extremely satisfied post-operatively. Important to note that the reading speed, especially when you are using Geometric Plus, even with a little low light, is good. Now here you can see to the left is the Geometric, which has very good distance vision. To the right, the yellow graph is a good near vision. When you're comparing and combining both the two complementary profiles, you get good bilateral vision. Now they also have the toric platform, so excellent rotational stability because of the frosted haptics and optic edge. So they give excellent results. So they have good visual outcomes, patients are satisfied, no minimal dysphotopsia, ease of implantation with the preloaded advantage, and the Vivinex technology has been time tested, which we have been using for all these years. So all this boosts our confidence. This was a patient who could use near vision also. This was just a few days post-op. So remember to undersell and over-deliver, and neuroadaptation is important. We take a special consent for all these patients. And to conclude, promising new technologies help us to give better visual outcomes and help us to have happier patients. Happy surgeon, happy patients. But just a word of caution in all these patients, they are like your lovely wife. You give them good chair time, counsel them well, they'll make a life heaven for you, otherwise they'll make life hell for you. Thank you so much for your kind attention. I hope I've been in time.
Thanks, Anaga, for that wonderful talk. But I think your talk was more biased towards lovely wives rather than the husbands. That's fine? Yeah, so that's what ophthalmology, women ophthalmology speak. Thank you, Anaga, for that wonderful talk. And I think that balanced approach, with the balanced energy is the whole concept, and it really works very well. So all to now we have Dr. Sheetal Barar, and she'll be talking on the enhanced monofocal isofocal technology. A very prolific surgeon, and a good news that she's now relocating to Chandigarh with her big sprawling center. So we all congratulate you, Sheetal, and good luck for your best wishes for your new upcoming center.
Thank you so much, sir, and good afternoon, everyone. I'll be talking about enhanced monofocal isofocal technology, which is the ISOPure enhanced monofocal lens from BBI. So while the traditional EDOF lenses were better off compared to the traditional multifocal lenses with regard to the side effects that they had, however, with time it was realized that even the EDOF lenses had certain side effects, but to a lesser level compared to the multifocals, and these were the loss of light, halos and glare, and loss of contrast as well. So this is where the role of modern enhanced monofocal IOLs kicks in, wherein they have limited the depth of focus to about 1.5 diopters or even lesser, which is given in the basically to provide functional intermediate vision without any loss of quality of vision. So basically these lenses have two aims. One is to give a post-op functional intermediate vision without any deterioration of the quality of vision. This is what these lenses promise. So I'm talking about the ISOPure enhanced monofocal lens from BVI, which I have been now using since quite some time. And basically this lens has a unique design. The design is a 4 closed haptic design with a posterior haptic angulation of 2 degrees. Now the overall diameter of these lenses is 11 millimeters. And you might wonder, the lens diameter is 11 millimeters, which is smaller compared to a traditional C-loop lens. So why? So if you look at the average capsular bag diameter after lens extraction, it is around 9.75 millimeters. And for a lens, for a diameter of the bag, which is 9.75 mm, 11 mm lens would actually suffice. So a 4 closed haptic design of ISOPure in 11 mm actually provides 70% greater contact angle and also 4-point fixation compared to a 13 mm C-loop lens. So this is the advantage of this design, that it provides a better and a greater contact angle and also 4-point fixation, which eventually improves the capsular stability of the IOL in the capsular bag. So the ISOPure lens also comes in a preloaded and a manually loaded injection system. The preloaded one basically goes through a 2.8 millimeter incision, and the manual one can go through a 2.2 millimeter incision as well. Now, the unique feature of this lens is the isofocal technology, which has been incorporated on its optic. And what this technology essentially is that they have incorporated negative spherical aberrations across the full diameter of the optic. So over the entire optic diameter, they have the incorporation of negative spherical aberrations, and also on both the anterior as well as the posterior optical surfaces. Now, this actually makes the lens completely pupil independent, and what it also does is that these spherical aberrations are further adjusted according to the IOL power of the lens. So basically, if your cornea is a myopic cornea or a hyperopic cornea, we know that the spherical aberrations are going to be different. So the other lenses, what they do is that they incorporate a fixed amount of spherical aberrations to the lens. So that does not give you a consistent depth of focus post-op. However, with these lenses, because of the isofocal technology, every lens has a customized level of spherical aberrations according to which are customized according to the thickness of the lens as well as the curvature of the lens. Now, because of this, what you achieve is a good balance between the depth of focus and the quality of vision with isofocal compared to the other enhanced monofocal lenses, where this balance is a little dysregulated. So coming to my experience with the isopolar lenses, I have implanted about 25 these lenses in 25 patients. 20 IOLs were implanted for 10 bilateral patients. The first eye was targeted for emetropia, or the first plus or minus, whichever was least. The second eye was operated within 2 weeks, and the second eye was targeted at 0.25 to a maximum of 0.5 diopters, depending upon the first eye outcome and if the patient desired to read better. So this is just a short video to show the implantation of the ISOPure enhanced monofocal lens. So what I like to do is to basically do a wound directed implantation and not a wound assisted. And I take the cartridge well within the anterior chamber, and I ensure that the leading haptics go straight in the capsular bag. And when the trailing haptics are about to open, I just slightly lift my wrist, so automatically the trailing haptics go in the capsular bag. So with this technique, you don't have to do any kind of manipulation while implanting these lenses. And you can see the surface of the lens. It looks absolutely like a regular monofocal lens. There are no rings, no optical element which can be appreciated. So the results at 1 month post-op were, the mean post-op UDBA was 6/6. The mean post-op CDBA was 6/5. The distance corrected intermediate vision at 66 centimeter was 0.14 logmar, which is around 7.5 to 6.9. At 40 centimeter, it was 6.9 to which is 6.9 or N8. The mean post-op SE was plus 0.12. And none of the patients complained of any halos or glares or starbursts at all. So reading addition in most of the cases was 1.5. For some it was 1.75 as well. And for some it was 1.25 diopters. And if you look at the internal MTF of the ISOPure lens, and I compared it with Technis 1 monofocal, you can see that average height of the MTF looks quite similar for the ISOPure compared to the Technis 1. And this is a subjective contrast sensitivity, photopic contrast sensitivity measured with CSV 1000, wherein you can see that the contrast sensitivity of ISOPure and the Technis 1 were fairly similar. You can see they are exactly similar for all spatial frequencies. And only at when the glare was increased, at maximum glare, there was a very slight drop in the contrast sensitivity at higher spatial frequencies. So these are excellent results showing that the lens gives excellent quality of vision post-op. So to conclude, the ISOPure enhanced monofocal lens, in my experience so far, provides excellent functional intermediate vision and also some amount of functional near vision, which of course, most of my cases, I like to do a 0.25 to 0.5 monovision as well. So it has reduced the need for reading glasses also for many of my patients. No drop in distance visual acuity, no halo glare or any kind of compromise on the quality of vision. Very high patient satisfaction wherein all the patients scored 95 or higher on the satisfaction score. So this is basically the combination of the closed 4 haptic design that gives a very good stability, a glisten-free high quality material, and the isofocal technology on the optic in combination that seems to work very well and provides excellent quality of vision in most of the eyes. And when I say most of the eyes, it means that eyes with any axial length, myopic or hyperopic, irrespective of the axial length, as well as the pupil size. So thank you so much for the
Thanks, Sheetal, for that wonderful talk. Just a quick question. Meanwhile, I'll request Dr. Chaudhary, Dr. S.K. Chaudhary, and he'll be talking on my experience with Minivel Toric. So I think we have 3 talks left, and if I can request all the 3 speakers to just have their bullet points, because Dr. Mahipal sir is here and he'll be chairing the next session on refractive, so we just don't want to impinge on his session. So Sheetal, I think that's very nice, and I think with the isofocal technology, I think the intermediate vision would actually matter with the extremes of the refractive errors, where it would, the extreme of hyperopias and myopias, where this lens usually outscores the other modified monofocal IOLs.
Yes, because of the isofocal technology that is customized for the IOL power, the thickness of the lens and the curvature, so it is expected to give consistent results irrespective of the lens power. So whether you have a high myopic patient or a high hyperopic patient, you are going to get around 1 to 1.25 depth of focus on the defocus charting. So
thank you so much. Thank you so much.
Thank you
so
so
all to you, Dr. Chaudhary.
Good afternoon, everyone. I am Dr. S.K. Chaudhary from Railway Hospital, New Delhi. Today I will be sharing my experience with toric EDOF IOLs. No financial interest involved in this talk. When we or our patient think beyond monofocality, then these are the options come in our mind: bifocal, trifocal, EMV, and EDOF. And when a patient has got corneal astigmatism, then how to handle this toricity? So we have these options. Till 0.5 diopter need not to do anything because patient tolerate it well. But when toricity is between 0.5 to 1 diopter, we have 2 options. Either we can place our incision at steep axis, or we can perform LRI. And when toricity is more than 1 diopter, then toric IOLs are the best option. If we talk about toric EDOF IOLs, they have distant correction, they have intermediate correction, they have fairly good near correction, and of course toric correction. And what are the surgeon's expectations from an IOL? So a surgeon always want wide spherical range, good cylinder range, IOL should be preloaded, delivery should be smooth, quick to unfold, good stability, and 2-way rotation in the bag in case of toric. And patient has also expectations from surgery from IOL. So what are these? Patient always want to be spectacle free. Patient want uninterrupted range of vision right from distant to near. Patient want good contrast, good night vision, and patient don't want any colored halos or glares basically. So to fulfill the patient's and surgeon's expectation, this is the market, this is the lens in the market from SIFI, Minivel Toric. So what is the mechanism? It's works by inducing spherical aberration in the center and paracentral part of IOL to extend depth of focus, thus providing excellent intermediate vision and good near vision without disturbing distant vision. And technology-wise, it uses wavefront technology to induce positive aberration in the central part of the IOL and negative spherical aberration in the paracentral part of the IOL. And we have experienced 48 implantations in 48 eyes of 34 patients by applying all the inclusion and exclusion criteria. And out of these 48, 20 patients are with unilateral implantation, whereas 14 patients are with bilateral implantations. In first group of unilateral implantation, 20 patients at the end of 1 month, they had unaided distant vision of 6.6 in 11 patients, 6.9 in 7 patients, and 2 patients missed last 2 lines and had only 6.12 vision. If we talk about near vision, N6 was achieved in 13 patients and N8 was achieved in N6 was achieved in 13 and N8 was achieved in 7 patients. And in group of bilateral implantation, 14 patients at the end of surgery of last eye, at the end of 1 month, distant vision was 6/6 in 12 patients, whereas 2 patients had 6/9 vision. And near vision binocularly was N6 in all 14 patients. This is the unboxed picture of IOL fully preloaded for hassle-free implantation into the bag. So I can say with confidence that Minivel is near to an ideal IOL because of its wide spherical and cylinder range. It's preloaded for hassle-free delivery and implantation, and it has got smooth delivery. It is quick to unfold. It has got two-way rotation and rock-solid stability because of its 4 haptic design. It has excellent visual outcome and continuous range of vision because of its optics, and it has got good contrast and undisturbed night vision because of its rings-free surface. So here is small video I have to show you. So as you can see, the delivery is pretty smooth. And in this patient, the marking was supposed to be placed at 90 degree. So not much of struggle. In single go placed at 90 degree. Thank you very much AIOS for providing me platform and opportunity.
Thanks, Dr. Chaudhary. I'll now invite Dr. Virendra Agarwal, and he'll be talking on press bypass correcting IOL. Holy Grail, he'll CR with the answer. So I think that's in addition to the talk we already had on synergy. So let's hear his personal experience.
Thank you, Sonu, and thank you, AIOS, for giving me this opportunity to share my experience with the Synergy IOL. And as you all know that the time is coming when the things are changing in a sense that you require something more than the monofocal lenses. And everybody is speaking something plus or minus for the lenses. The question is that we need really something beyond monofocal. So the question must be understood that the patients who are having cataract, I'm not saying for the clearance section, are having some or other visual disturbances, and to cover that up, I don't have any financial interest in any of the lens or the lenses I am going to discuss. So monofocal or monofocal plus is not the only answer because the patient requires much more vision, and particularly for the Asian eyes, you require a distance and near vision at a slightly closer distance, not 40 or 60 centimeters is required. We require actually at 33 or less than 33. So there are so many studies, and the patient profile is changing and affordability is also changing. I still mean that the patients who are not having to afford the high cost lenses, can go for monofocal or monofocal plus, but definitely given the choice, and as Dr. Mehta has said, the ultimate cost comes less for the multifocal or bifocal or trifocal or the continuous range of vision lenses. That is the reason that it can be a lens of choice for every state of life, the scenario. And we have to fill in the gap, which was there with the bifocal and trifocal. The bifocal and trifocal, you can see there were 2 or 3 clear focus, but these are not the life scenarios, and what we require is a continuity of vision. And as Sonu has said, I will go fast, so I will have less of the slides presenting. And this continuous range of vision lens, you can see that actually this from here to here, it is within the range where it can give vision of comfortable level. There are other lenses just to show the comparison. There is a trifocal from the Zeiss, from the Alcon and Physiol. So they all are not having the continuity into that sense, but they are also good lenses. And trifocal lenses, I'm just going to show again the MTF and the logmar visual acuity. They are different lenses calculated and analyzed, but their distance, near distance was more than 36 centimeter. And that is not there particularly for the females because the shorter arm length, and even Indian males also don't have a comfortable distance beyond 33 centimeters. It is a good mix of two things which Ajay Sharma has already pointed out, the multifocal and the symphony lens. But the important things are that basically why the quality of vision is good with the Synergy lens is that the chrome aligned technology is one thing, then Ashlet design is another thing, and a violet light filter. So these two things, the Ashlet design and chrome aligned technology were there in the Symphony also, but that was not having a good vision for the near vision. So now adding with the multifocal part into it, we are having a good near vision, intermediate vision, distance vision, and that too with the continuity. So that is the main reason the patient's expectations are fulfilled and they are happy. The violet light filter plays a role in particular today's life where we are having more of LEDs and they emit violet light that causes more of a glare. That was the issue mainly for the night driving, and many of the people among ourselves as a doctor don't advise, and many of the patients are afraid of that they will be not able to drive. Somebody has shown in the beginning previous talks that somebody who is doing a regular night driving. I want to just add on the word regular night driving from work place to home, that is around city driving for 2 to 5 or 10 kilometers is not a contraindication. Those who are doing regular highway driving for their professional reasons can be candidates who are not very good for these kind of lenses, but rest all can be a good candidate. And unless you explain them what is the need of the near vision in day-to-day life, they don't understand the importance of it. And many of the patients who actually, because of some or other reasons, because of the taking opinion from the different colleagues, they go for monofocal, and after implanting them, they come, sir, I have gone for a wrong decision. Can you change it? I'm not advising to explant the lens and implant this lens, but we should give more enough time for the patient to understand the importance of these kind of lenses, then the majority are opting it. So that is the reason that I keep telling to the patient that my first choice is this lens, and then comes the advanced monofocal and then monofocal. And no negative for any company, but when they compared between the Synergy and Panoptics, the conclusion was that the Synergy has shown the extensive range of vision, particularly through near distances and better mesopic performance than Panoptic patients undergoing cataract surgery, and the same is my experience. And this is because of this reason that when you compare this part, this is the Panoptics and Synergy, the difference is that at what distance they are maintaining the vision for near, and because of this, the Indian patients are more happy. I'm not going to detail what preoperative has done because Dr. Ajay Sharma has clearly highlighted. Dry eye is the most important, topography is another important point. And why I'm saying topography is important, like in this patient, you are seeing the cylinder is just 0.5, you can avoid it. But when you do a topography, then you realize it is having a dry eye effect, and because of this, the dry eye patient need to be treated first. If dry eye improves, then only go ahead. But otherwise, all sorts of patients, all professions can be done. I'm just going forward. And the conclusion is the visual needs are changing, visual expectations are changing, demands are changing, and because majority of the patients and doctors are now implanting, we have enough pool of these diffractive lenses implanted. So the patient's understanding and patient expectations are also changing, and they are accepting it much better. Even before surgery, their neuroadaptation is coming into play. that at the cost of rings, they are getting better quality of life. And as Dr. Mehta was saying, the quality of life is the most important thing. If we impress upon them that somebody was telling me in the morning that how much time you do driving or something is less than half an hour. And rest of the time you require a quality of vision, so go for these kind of lenses. So this is my also opinion that independence from glasses for majority of the distance or reducing the dependence on the glasses is the need of the time, and CRV fulfills this kind of lenses needs. So my choice for CRV is that I should go for all patients unless they are having some negative of the dry eye, macular pathologies or corneal irregularities, we should go for this kind of lens. Thank you very much. Sonu, I hope I have saved your time.
No, thank you very much.
Thank you, sir, for that wonderful talk. It's my pleasure to invite the last speaker of this session, Dr. Sonu Goel. He needs no introduction. Terrific surgeon, excellent clinician and speaker, as we all know him. So over to you, sir. For your
Thanks, Sheetal. And I think we had a wonderful session all throughout for all the IOLs. So I'll just also try to brief up of the entire gamut of lenses that we had. So we all know that there have been repeated surveys by the EACRS, and there is definitely a drift in the international market from multifocal to trifocals and from monofocal to EDOF IOLs and modified monofocal IOLs. And I think that has actually helped us pushing in two ways, getting more finances and getting our patients more crystal clear vision. Now the challenges has been, as we have all discussed, the accurate IOL power calculation. I think residual refractive error is one of the key important point in when you're dealing with these modern IOL technologies, and I think we should all have the best of the IOL material in the type, and I think good surgery which includes proper centration and orientation of the IOL, because as we know, a tilt more than 2.8 or a decentration of more than 0.5 is very deleterious for these premium trifocal lenses. A quick word of the Holiday corneal power decision tree that we follow in our hospital. This is the patient lens up, goes directly to the keratometry. If the standard deviation is good, whether there is a toric, goes for a topography in the 4.5 central millimeter zone, and then we calculate out depending upon the Barrett formula. If there is no cylinder, directly goes to IOL Master 700, the IOL power calculation. If the standard deviation is more than 0.2, look for dry eye. Treat the patient for more than, between 4 to 6 weeks, and then we take the patient for the cataract surgery. Otherwise, if the patient still has on the topography, you find out keratoconus or a pellucid marginal, the patient goes on a tomography, pentacam, and then you calculate out the back surface and the exact power calculation. So I think this one good calculation is very important. So preoperative evaluation for all the lenses. So I think in modern day cataract, no lens is premium, but the patient is premium. So good dry eye assessment, topography, higher order aberration using a ray tracing, angle alpha kappa, specular microscopy, macular OCT, a good optical biometry is very, very important, and a personal touch to the patient for a few minutes, chair time is very important. Now, surgically, what is important is looking at the pupillary aperture. I think we all ignore the size of the pupil. So preoperative selection, pupil size is very, very important. During the surgery, the IOL tilt and the decentration, and that is where the effective lens position comes. So a good centered round regular axis, placing the lens in the bag, not compromising with the tilts, and taking care of the corneal aberrations is very important. And when we talk of aberration, we know that the corneal root mean square less than 0.3 is an ideal, but more than 0.5 is not acceptable in these lenses. Similar goes with the angle alpha, less than 0.4 is acceptable, but anything more than 0.5 or 0.6, I think monofocal lenses stand. So a quick word for the recent, the fine vision lenses that we've been using, amazing trifocal lenses, and a very small experience of 2 months, 50 lenses that we had. The patient had good distance, intermediate and near with hardly any photoptic symptoms. So this is a 6 millimeter optic zone with 23 rings in the center. It has a central 1.1 bull's eye, and this is a double C-loop design, and these are frosted, and this actually helps in preventing the optic haptic snug or the kiss that we usually encounter with the other lenses, and takes time. It takes no time in unfolding. So this is always the leading haptic on the right, which guides you, because this has a 5-degree angulation. So this has always to be on the right side. And we have innovated because this helps us. Sometimes you can actually hook in the Kugeln here and helps in dialing the lens within the bag at times when the pupil shut down and you feel that the lens is, the haptics are in the sulcus. So this has the diffractive pattern on the anterior surface and the toricity and the asphericity on the posterior surface, a good rotational stability, the availability both in the toric and the non-toric forms. And the lens design is actually what gives us a good toric stability. The material, it's a glistening free yellow material, a very long-term study over a period of more than a decade, and this has stood to the time, and this has been a hydrophobic material, a combination of both the UV protective and yellow lens. So minimal photic phenomena, and this minimal photic phenomena is basically attributed to it is called as the copod design. And what copod design mean, I'll actually come in the subsequent slide. The second advantage with this lens is the near vision. I think this near vision outscores vis-a-vis all the trifocal, because it has a add of 3.5, and at the same time there is a higher energy allocation for near vision. And it has a very smooth transition between distances. That means intermediate, near and distance, and that is what gives you a continuous range or unified vision all throughout the distances. So this is what we actually mean with the copod design. And we all know these are the apodization, and this apodization along with the convolution. So convolutions, if you smoothen out these ridges, this takes care of the photoptic symptoms. At the same time, it helps in working in harmony with the pupil, managing the risk of glare and halos. So if you see the picture there, this is what the apodization, and these are the truncated sharp edges. The moment you make this surface convoluted, just watch carefully, this smoothens out, and this is how it takes care of the smoothing, and this actually transforms into this kind of phenomena. So if you have these truncated edges, you have these starburst phenomena, but the moment you combine it with the convolution, the phenomena is taken care, and this, the night driving picture would look something like this. So I think with this copod design, which actually takes care of the photic phenomena. So it usually, as I said, for the near vision, so this is the distance intermediate and near at different pupillary sizes that the lens works. So this is the slide which shows the range of vision that this lens, the defocus curve, and this works almost greatly at all distance intermediate and near vision. And this is the design that we have. So with the C-loop design, you always tend to rotate it in a clockwise fashion, but this actually ensures that you can rotate the lens in either ways. So quick maneuverability is very important here. At the same time, it gives you that kind of rotational stability because the area of contact with the bag is too high. So it is available in the toric lenses also on the toric platform, and the toricity lies on the posterior surface of the lens. And at the same time, it has a low PCO rate, and this is basically of the pod design that it has. Long-term studies at various institutes has actually demonstrated over a period of 3 years, hardly any PCO rate, though we have a very limited experience of over 2 months, 40 eyes. So thank you very much. Sorry for the paucity of time. I had to rush for the slides just to introduce this wonderful technology to you all. Thank you very much, and I'll thank Dr. Mahipal sir for bearing with us for the shootout that we had on his session. Thank you, sir.
Thank you. Thank you, Sonu. Thank you for summing it up so quickly and so effectively. And thank you all for being with us all through, although we are running late and we have to give the session to Mahipal to chair. So over to Mahipal.